Hey everybody, welcome to Medicine 3.0, your podcast for AI in healthcare, and living your optimal life. This week, I'm super excited. The head of Duke Cardiology, Manesh Patel, one of our advisors, came and talked to me. We covered so many great things about heart disease, how to think about risk, how to be healthier. So I hope you enjoy it. All right, Manesh, let's just start off your story. I kind of tell people, especially with physicians, I feel like everybody's got an origin story, kind of like a superhero. What's your origin story? How did you end up where you're at?
That's great. It's interesting. I won't go too long into it, but I like a lot of people really didn't know if I was going to be in medicine. I was actually born in Africa. My parents are Indian, and they were married in India. I was in Uganda, born there, and then Idi Amin came in, and my parents left. So sort of a real immigrant story. Went to Canada and the United States. Grew up in Georgia. Thinking going to college, went to Vanderbilt, just enjoyed college, thinking, I'm going to do something in business, not sure what. Eventually, like all parents there, I'm sure a little bit of rebellious, like, oh, I don't want to go into medicine, but did enjoy science and eventually got interested and then went to med school at Emory. The best part of going to med school at Emory was the Grady Hospital because I was a medical student in the late 90s and I guess into the mid 90s. And, I got to see patients and got to do things in a medical school at times where I felt like I was making a difference. And so really enjoyed that transition from the lecture hall to the clinical wards, and then came to Duke. When I came to Duke as an intern, it was just days of learning how to be a good doctor and see patients and care for them. And I saw a lot of cardiologists doing those kinds of things. One of the things that brought me to really want to do cardiology was that it was an opportunity to see people across the life course, and you got to see them in clinic, you got to see them in procedural labs, you could take pictures of the heart. There's just so many different things you could do at that time. And there's a lot of innovation, to be very frank. At that time in the early 2000s, new therapies, new devices, stents, procedures, drugs. So there's just a lot there. So that's how I got into it. And it's been a great journey, and I'm excited to be able to do it. And now spend my time as an interventional cardiologist at Duke, but also, working to train the next generation and think about the things we can do to make a difference.
That's awesome. I mean, it's kind of the story of a servant physician and somebody who wants to train others and be involved in innovation. When you were making the decision, I feel like every specialist thinks their organ is the best. How do you make the case that the heart is the most important organ in the body to think about?
I mean, they're all very important, right? And when you have one wrong, that's the most important one to you. And
That's
so I
right.
don't, right? Like, and certainly, I was interested in med school and the brain a lot too, in neurology, and talk about the complexities of the human brain. I think the way I think about cardiovascular disease and the heart, in essence, is in its most basic form, it's a pump and it has valves, electrical function. I tell patients all the time that, that it's beautiful, but it's not tremendously complex in regards to at least some parts of how it works. But it's so important to us because unfortunately so many people suffer from the things that lead to problems with your heart or your heart arteries or the arteries that go to your body, including your brain, that when I was involved in it, it seemed like it was so many people you could be touching while you still had the opportunity to make a difference if you did it acutely. So I was just on July 4th with our new fellows on call over the weekend. And, patients acutely ill coming in with our interventional fellows saying, in this moment, we're going to go to the heart with this catheter and see if we can open up a blocked artery. That's immensely fulfilling if you can get it done. And it's very rewarding to you, hopefully to the patient as you get that done. But it's equally rewarding to talk to people in clinic over years and say, hey, we've made this difference in your risk. And this is what we're doing to make sure this doesn't happen. So one of the reasons I thought the specialty was exciting, and why I tell people it's still potentially one of the more exciting specialties, is it gives you the opportunity to build relationships with people long term and carry them through, I'll call it the good times and the bad times, to hopefully have the most meaning.
Yeah, you know, I love the heart, and there's a couple interesting things. Of course, I was in the ER for 10 years, and so did a lot of code STEMIs. And like you said, it is extremely satisfying to take somebody that, 30 years ago would have died or not had a great outcome, and then as a ER physician, stabilize them quickly, see them get to the cath lab within 30 minutes of arrival, and hear back from my colleague in the cath lab calling me and saying, hey, we just opened up this artery and this patient's doing great now. So that's tremendously satisfying from the ER side. From the cardiology side, I imagine it's even more satisfying to actually do the procedure that saves the person's life. And then I think that longitudinal relationship that you're able to have. The other thing is, part of the reason I started Bionic Health, and I can't remember if I've told you this before, was my brother-in-law had a massive MI in his left anterior descending on a bike ride and died. And, he was 62, he was a mountain biker. You never would have thought, like, this guy is at high risk to have a heart attack. So that kind of makes me wonder, how do you kind of talk about risk to people that you see? How do you kind of think about risk for people's heart having an issue with it?
Well, this is potentially one of the greatest opportunities that exists in cardiovascular medicine, and it's one of the greatest existing tragedies still, right? I mean, the story you just told, and we all have someone that's touched our lives or we know of that's had this happen. And I wish, and we are still working to say, can we find and predict who's going to have that plaque rupture or that blockage that leads to that? And everyone's at risk for it. So, unfortunately, because it's so common, we have these conversations with our patients, and I'll talk about that in a second. But, I believe one of the biggest steps we could do is move towards better understanding of not just risk, but actually having a system where we go and screen and prevent heart disease. If we weren't talking about heart disease and we were talking about cancer, no one questions that there's a cancer moonshot, and at age 45 or so, you need a colonoscopy or a mammogram or a variety of lung screening if you've been smoking. No one questions you should have other types of screening for certain disorders. But for the leading cause of death and disability worldwide, we haven't yet figured out how to predict as best we can who's at risk. And so a lot of our conversations and a lot of the complexity is that there's so many people at risk that this is potentially devastating. And a way to think about that is the American Heart Association on it. This is their 100th year anniversary, and they just published a paper on the projections to 2030 and beyond. And unfortunately, the United States, it doesn't look better. We're working, we've made these strides. We open up arteries fast. We've certainly improved heart failure patients. We've reduced the mortality from a heart attack by 30 to 50% over the last 100 years. But there's still much work to be done, because over the next 30 to 50 years, hypertension's going up, obesity's going up, diabetes, cholesterol might be flat to a little up, but still stroke rates and heart attack rates are going up. Obviously, the population's aging. So what I tell people in a clinic is that's all the big picture population data, but what about for me? What's my risk, right? And that's where I think things like, whether it's Bionic Health or others, where we can get more specific about individuals will matter. The current science is that we take what we call epidemiologic data, or data on a lot of people, and try to apply it to individuals. And the way that works is we say, risk factors that we all know of: hypertension, cholesterol, diabetes, tobacco, family history. We plug these into different kinds of calculators. Sometimes now some kidney measurements that might tell us something, and some other metabolic measurements. And we take that and say, okay, your risk of having a heart attack over the next 10 years is X, 7.5%, 10%. And when we get to a certain threshold, we start trying to treat you and prevent it. I think that's a very scientific and appropriate way based on the guidelines. I hope we get to saying, hey, there's a reasonable, lower cost test, whether it's a sound or a blood test or an image that says, this is your risk and this is what we need to do.
Yeah, I think, like you said, it's, how can, at the personal level, how can we screen somebody appropriately, and then the right therapeutic or lifestyle changes or whatever it is they need. And you named all these different risk factors for heart disease. And I feel like one that, we have medications for. So, I mean, I guess we have medications for many of them. We have metabolic disease medications, we have lipid medications, we have blood pressure medications. And I've heard it argued before, like if we just focus on LDL, and you drive LDL as low as possible, then you'll decrease that risk. And I've even heard people argue like you should try to drive it to teenage levels. Of course, that's a little confounded today because we have teenagers with high LDL. But what is wrong about that way of thinking, and what might be right about that way of thinking? And partly, I think it's just too simplistic. People try to simplify things, and the body doesn't always want to simplify.
Yeah, I think that's right. I mean, I think the first thing is what we're also learning is that the biology is more complex than we think. And so just to go back to our sort of our understanding, and I tell our fellows and my patients that this is our current cartoon thinking of how the plaque in your body works. And we can actually image it sometimes with CT and other things, but that plaque has cholesterol being put down into it with macrophages that are coming because of inflammation. If it heals, it leads to calcium in the wall. That plaque can have components that we believe, like you said, the LDL, which we want it to be lower. So the total cholesterol, the LDL is the number that we say some people say, is that the bad cholesterol? I'll just tell you, we used to call HDL good cholesterol because it's been observed that when it was high, people had less events. So that is a pattern, but there are no therapies that raise HDL that make you have fewer heart attacks. So I won't call it the good cholesterol. I'll just say it's associated with not having as much of a problem. The LDL being high is bad, and when we lower it, it does look like over population basis and for individuals, it can reduce the risk. The issues are, what other risks do you have beyond just this HDL, LDL world? And there are things like lipoprotein little a, ApoB, and other markers just of the cholesterol. And then there are inflammatory markers, and then there's some other markers. So the possibility is not only that you likely have some genetic risk factors, but you might have that being expressed or being shown in you through these different biologic tests we could do. And so what I often tell people is you want to know your numbers. Those numbers are important. You want those in context of the other numbers. You want those in context of your other risk factors. And then you want those in context of what you can tolerate and do, right? And as a clinician, often I'm saying, where is this person in their life course? Is this a 30-year-old active basketball player on the weekend who's wants to do this and this, but unfortunately has had some heart disease in their life? Is this a 75-year-old person who's retiring who's not had heart problems or has heart problems? So that it sort of depends on the context of the individual. But you're right. Big picture-wise, I would say that the idea that lowering LDL long-term improves cardiovascular outcomes is absolutely right. And for individuals, depending on where they are on this risk continuum, I often recommend that we need to get on that train of lowering their LDL or improving their cholesterol. That can happen multiple ways. We can get into sort of what are the dietary things we know science-wise, what's activity, and what are the drugs or other things. But that's really important. At the end of the day, it's the habit you form that you can keep and the health you get that gives you joy. And the two have to be linked. And so I often tell people, if you're really against some of the therapies we're talking about, I'm not opposed to it. I need you to be on my team. Let's try what you want to do. But if we can't get there with what you want to do, you have to understand that I'm a cardiologist, so I may be biased, but I'm trying to take the global information and say, the global information is, it's like I tell them it's like an area under the curve function. LDL can be thought of as a toxic substance if there's too much of it around in your blood. The more of you have it over your lifespan, the more that area under the curve grows, the higher your risk grows. So at any point, if you can lower it in any way, it's usually pretty good.
Yeah. I do want to ask you about some therapeutics, but I want to go back to where you were kind of driving things before, because I think that is interesting to explore, and the idea of kind of universal screening in the future, and maybe how you would think about it if somebody could afford their own screening. So universal screening is usually, it's only universal because insurance says, yes, this is going to be paid for. Otherwise, it doesn't become universal. But if somebody had money to pay for their own kind of screenings, how would you kind of think through, this is what I'd lay out as what you should do to figure out your risk?
Yeah, the first is sort of, when do you do it?
Yeah.
That's a big issue for us in the field, right? And I think that's part of why we haven't accomplished the universal screening bit. And I say that because I think you have to do something when you have a chance to make a difference, but you have to do something not too early, because then you do so many people that you don't find enough people with a problem where you can make a difference. So that's the sort of public health way of thinking about why we're not there in cardiology right now, or in cardiovascular medicine. Because when the 2030 data I was saying, so if you count hypertension and some of those risk factors, but the AHA is projecting 61% of people in the United States will have some form of cardiovascular disease, with 161 million people potentially affected. So if you're starting to screen 161 million people, that's why you got to either have a very low cost screening or a much more specific screening and therapy pathway. Now, that being said, look, a lot of people have resources and are wondering, hey, how do I prevent it from me? And I see this in clinic all the time. I'm sure you do too, and see it. So there, I think the time period for me is if you've had family risk, or you're interested, or you're just a person who might be at risk. I think generally somewhere in the early 40s is probably where you're going to find that sweet spot. That doesn't mean there can't be some people younger. Certainly people that are beyond that should be at least thought of thinking about it. Once you get to 65 or 70, obviously you may not screen, because you're saying, well, look, you've gotten this long without. You should still know your numbers, but whether you get screened or not, that's a question that I think people have to think through. But I don't know that there's ever a bad time. It just depends on what the tests are, right? So if it was a blood test, you could say, hey, I'm going to do it all the time. If it's an imaging test, there's kind of different things. So first, I think if I'm in that 40 to 60 range, and you're saying, hey, I'm going to need to understand my cardiovascular disease, in addition to standard stuff like blood pressure, weight, heart rate, things that you should know, I'll call them average regular biometrics about yourself. And these days with an Apple Watch or whatever gizmo, you can probably get a lot of those. I've got a ring and a watch, and I know my sleep schedule, et cetera. So we're getting more and more data about ourselves. So I would say that's number one, where your body weight should be, what your heart rate should be, what those things are. But beyond that, for cardiovascular, I do think there's a set of blood tests that we discussed a little bit about, which is not just the standard cholesterol testing, but I think there's actually sometimes an NMR or different types of profiles that'll give me an ApoB, let me know a little bit about someone's Lp(a), certainly tell me about inflammatory risk, whether they use a CRP or other things. I think that's really valuable. There's a few other sort of subfractions that might be of interest. Making sure that we know their metabolic state. Do they have risk for diabetes? Do they have, even if the A1C is not fully up, is it somewhere where it could be up? Where's that? I think those are going to be pretty interesting. Then I think after that, most people think there's some sort of an imaging study to see is there vascular disease. The one that's probably most discussed right now is a coronary scan of some sort. There's a calcium scan, which tells you, as I said, calcium, if that plaque heals into the wall, gets formed. So I often tell patients when they come in, the fact that you have calcium at a younger age says that there's atherosclerotic plaque that's been healing into the wall. Now, whether it's also obstructive and whether that plaque is vulnerable is a different and important question. So the calcium score just looks at calcium. A coronary CTA or coronary angiogram of your coronary arteries, where they actually give you iodinated contrast in your IV and they look at the arteries. Now they're looking at the wall, the calcium, but also trying to look down the vessel at plaque. Sometimes calcium can obstruct that. There's a variety of software programs now that help clinicians and doctors look at that. So there's some that look at how much that flow is reduced. There's some that are looking at the total plaque burden and the type of plaque. And so I think that's going to be really an area of great, not just research, but opportunity for our patients. So if you have means, getting those blood tests and potentially considering a CTA of some sort to get your total plaque burden. Now, if you have any risk, I usually do blood pressure in both arms. If you have any BRUI, any carotid athero, any atherosclerosis anywhere else, I'd like to know that too. And that would drive my reason to get your cholesterol down lower, because now I'm finding plaque and in different places. What's coming? I actually think we get back maybe later into the conversation around data and AI and what's coming, because I think there's going to be a lot there, and especially this space for cardiovascular. But one of the places people are doing, maybe I think the first level of that's going to be just regular retinal eye scans, because what we see is that a lot of the opportunity actually, it may live in the fact that in the back of your eye, there's retinal vessels. They're actually being visualized just like we're trying to. And if there's changes, even small changes with plaque or blood pressure, it starts to tell us the person's risk. So I know of places that are starting to say, hey, we're going to do a CT scan and non-invasively just have some back of the eye retinal images. Those are the kinds of things coming. Today, what I would recommend is the blood test, the usual stuff, probably a CTA. That helps you feel comfortable that you don't have significant obstructive coronary atherosclerosis.
Yeah, and you kind of alluded to this, the fact that any plaque can rupture. That if you have plaques in your heart, then you're at risk. And then there are all these other risk factors like inflammation, like metabolic disease. Are you a smoker? All those kinds of things. Are there other risks that you talk to your patients about or that you think about that aren't kind of like on the normal list of risks? Like you kind of mentioned sleep, I don't know, stress. Are there other things that you think about when if you're going to think about that?
I think a good base is life's essential 8, that the AHA speaks about. And I think I'll call it, it's not just for cardiovascular disease, right?
Yeah.
These 8 things, if you manage them primordially throughout your life, you're going to prevent things. So blood pressure, cholesterol, diabetes, weight, those things are really key. And then sleep, activity, and diet are going to be really critical. And I think people understanding those things, and then not smoking, of course. And so those 8 things I'll call baseline health. And actually, if we count how well, if you do really, really well on those 8 things, you do a lot down the road, right? Beyond that, though, so those are what I'll call the things you hear about all the time. I do think chronic stress or stressful things play a large part of cardiovascular disease. And the way I explain that to patients is your heart's a pump. And imagine you're at a stoplight and you step on the gas, your engine revs and, the car doesn't like it, you don't like it, but you're just doing it because you're kind of feeling good, like you're going to go do stuff and right, you're going to take off the line. So the stress response is if we were in the same room and there was a snake, of course our blood pressure, heart rate is supposed to go up. But what's happening for your body when the stress response is happening, when that stimulus isn't there, is you're perceiving that something's going on in your life, whether it's stressful situations, those things. And that becomes then something that's chronically making your pump, your heart, your vessels squeeze and work harder. And over time, it's been demonstrated that chronic stress can lead to certainly increased blood pressure, but also increased cardiovascular events. The environment is another huge piece that we're not talking about right now. If you looked at those projections, likely environmental exposure, whether it's not just sun exposure, but air quality, a variety of other things are probably playing a pretty large part of cardiovascular risk. And then chronic infection. So, it's good to prevent yourself from having the flu and other infections, because when we see people that are unfortunately keep having different types of infections, that revs up the inflammatory system, revs up the stress. So the most recent study showing that, not getting the flu, whether it's with vaccine or avoiding it, improves cardiovascular population is true. I think the environmental effects of air quality have been seen and are going to be critical again. So trying to think through that. Some of that you can control, obviously some of that you can't. And we're starting to see a bunch of stuff that people would probably be interested in on microparticles and certainly plastics and things, not just in plaques, but in dietary things. And so water quality, air quality, and then food quality are going to only increase as the world gets more and more populous. On an individual level, not all of that's measurable. Most of what we talked about earlier is measurable. I will just end by saying sleep is probably the superpower thing that we don't speak to enough. Chronic sleep deprivation, poor sleep, poor circadian rhythms are all associated with adverse cardiovascular events. And so finding ways in which people can reproducibly rest, download, reduce that stress, improve their sleep quality is another finding that seems to improve overall health, but certainly cardiovascular health.
Yeah. So we talked a little bit about risk assessment, screening, and I'd love to hear a little bit about, okay, we find that I have some risk. I have some plaque and I want to decrease from where I'm at to being at less risk. So I'd love to hear your thoughts on, let's not cover exercise. We'll go through like diet
Yeah.
and then medicinal therapeutics
Yeah.
and how you think about that. So somebody comes in and how you would talk to somebody and they said, okay, I want to decrease my risk. What would you lay out for them?
Yeah, for sure. We're going to pass exercise for a bit, but obviously a critical component and probably one of the more important components, not just because of the habit forming, but it makes you think about everything else you do if you can get exercise every day or every other day or some fashion. And
Yeah.
hopefully provides joy to individuals and when they do it, if you can find that activity. So beyond exercise, what I think about is the hardest thing people ask me all the time is what should I eat? And it's the scientific question that has the least answers to it in a really good way. And I actually think this is books and dozens of books and plenty of, let's just say, faux pas in the way we describe what we should do for eating. The best available science will not strike anyone as any new information, which is generally the Mediterranean diet has been shown to improve how people have cardiovascular risk and their health is better. And when we even look at the like blue zone people that live to be very long and don't have cardiovascular events, they tend to be in Mediterranean regions, and the diet is probably tied to an environmental tie. But the keys to that diet and the randomized trials or even some of the observational studies highlight that they tend to be local food, that tend to be oils, fruits, vegetables, but lots of grains and lean meat. And so that's the kind of stuff that we sort of generically tell patients. The problem is in the US or around the world, like, what does that mean? What do I do? How do I do that? And everything from, well, is the Atkins bad, paleo, to intermittent fasting, to I'm going to try this. All of them, I think, are possible. People have to think through what they're trying to accomplish. If the diet is being used for weight reduction, that's different than a healthy diet. I just want to say that. And so what we try to start with is just saying, actually, if you can eat a healthy diet and increase your activity, you will hopefully start to get to the parts of where you can get to weight reduction. The features of a healthy diet do include trying to make sure, if you can, you're getting some sort of protein and some sort of, I'll call it grains, vegetables, and fruits. Carbohydrates aren't bad. There's this whole idea that you shouldn't have any carb. I'm going on a low carb diet. Certainly for weight reduction, there's some features of that seem to work, but they should be hopefully not processed. The one thing that seems to be the biggest role that we can find is that ultra processed foods with trans fats, foods with a lot of complex and sort of fabricated sugars are not great for diets. So that's the way I start with patients, and open to your thoughts about that. And then if they ask about weight reduction, then we can talk about some specifics there. But that's the way I start with what I'll say is a healthy cardiovascular diet.
Yeah, I mean, I totally agree. I think the best science says Mediterranean. It's too bad there's not like a place in the grocery store that says Mediterranean diet here.
Yeah.
It is.
And it's hard, like, because people say, well, what does that mean? And I try to tell them, like, it tends to mean that you can eat a lot of different things. The Mediterranean diet includes a lot of it, but it tends to be more things that swim and fly and fewer things that walk around on planet Earth. And it tends to be, more things that grow from the ground than things that are under the ground. And so if I'm in the grocery store, I tell people, think about it that way. Wherever sugar is stored tends to be stuff you want to have less of. So if that's a big starchy vegetable or a sweet object, you want that, but you want that after you've had some good fiber, some good vegetables that grow from the ground, and some meats, ideally lean and otherwise.
Yeah, no, I like that. I tell a lot of my patients, I really like something called the 800 gram challenge, which is just try to get 800 grams fruits, vegetables, legumes every day. And that'll kind of do that part of the Mediterranean diet for you. And
I think
then,
that's a good tip. That's a really good tip.
yeah, so it's 6 cups of servings or 800 grams if you want to measure it out. So I like that. But let's move on. So
I'll just say one other thing I'll tell patients about that. Sorry, yeah. The other thing I tell people in the American diet or in the diet that we all have is, and this gets into some of the weight reduction, but also the strategies, is trying not to eat too late and trying not to eat too early. Not that you have to get to a full intermittent fast, but if you can have energy occurring during the day when you're active and not when you're not going to be active, that helps. Yeah. And then if you start thinking about time in your plate, that if you start at noon and you get to 6 o'clock, that half of the plate should be vegetables and legumes.
Hmm.
From 6 to 9 o'clock on that plate, good lean protein. And from 9 to 12 is where you could put carbs. And if you look at your plate every day and try to put that on your plates, you'll generally do better.
Yeah, I like that tip too. And I mean, there's something about restricting your feeding time. It just helps you decrease the number of calories. Because I mean, our ancestors didn't have to deal with having too much food around, but we do.
Yeah.
Like we
Yeah.
constantly, especially if we eat highly processed food, because all of a sudden we go from, a head of lettuce that is this big and going to take up that much of our stomach to something that is this big and has 3 times the calories. So there's some trade-offs for sure.
And it is partly the secret of the Mediterranean diet is that it's just local.
Yeah.
It's stuff that's in the area that's not having to be processed. So even the breads don't last more than 2 to 3 days. And they don't. So everything we're getting is just being produced to be around longer, and that requires all these things. Whereas I think if you can eat local, that will help you.
100%. I make sourdough every weekend, and the Mediterranean diet definitely has sourdough bread in it. So I tell myself while I'm eating that I'm
Yeah, this is Mediterranean, exactly.
Exactly. So I'd love to move on to, okay, we talked about diet, and I mean, I loved that you couldn't skip over exercise, because you and I both know how much exercise affects everything. And I constantly talk about exercise. So thank you for not skipping it, even though I told us that we were going to skip it. But now let's move on to, okay, how about medication therapeutics? How do I think about this? What kind of changes can I see? What are the costs? Those kinds of
Yeah. So let's start with just the cholesterol or the LDL reducing therapies, and I'll just start by saying, if I lived in a world where I knew nothing about cholesterol, I didn't have access to the internet, and somebody said, I'm going to give you a pill that's been studied in roughly randomly, where people didn't know what the pill was, whether it was just a placebo or this therapy. It's been studied in nearly 600,000 people and shown to reduce them from dying from heart attack and stroke. And the mechanism, best we know, is probably multifactorial, reducing inflammation, but certainly reducing LDL, broadly, tolerated, and comes without a high expense. We would say that's a pretty good thing. That exists. It exists for blood pressure with blood pressure medications, and it exists for cholesterol with several medications, the most notably being these HMG-CoA reductase. These are fancy name for a statin, which inhibits a pathway in your liver to make this cholesterol. And so these medications like rosuvastatin or atorvastatin or Lipitor or Crestor have been studied to reduce cholesterol and reduce LDL, and they do. And they generally, when they're used at moderate to reasonably high doses, they reduce that LDL by about 50%. So, if your LDL is 150, it can get below 100. It can get towards 70 with a reasonably high dose of that. Now, obviously, because any therapy gets approved, it should be used in broad practice. And as it does, people do have side effects, as often talked about, or adverse effects from those. And they're real. I don't want people to think I'm suggesting that they're not existent. I just think that the number of people that actually have them coming from the statins versus not is complicated. We have to work through that. That therapy, I think, is probably first line and probably important. There are other therapies too. So just walking through some of these others. There's a newer drug now called bempedoic acid that actually is a step or two above HMG-CoA reductase. So it's in the same pathway. It's a little earlier. It's not in the muscle tissue, that enzyme. So if there was some muscle aches happening from cholesterol-reducing medications like statins, this drug seems to have less of that, both biologically and observed in trials, and also seems, at least in 1 or 2 trials, to reduce cardiovascular events and things like that. There's a drug called ezetimibe or Zetia, which also has an opportunity to reduce cholesterol, and it was tested on top of cholesterol medicines. It provides another 10-20% reduction in that LDL and seems to have an improvement in those events. There are some medicines we take that have less of an effect, but they bind cholesterol. They've been studied to use in some strategies for people who can't tolerate those other medications. I think it's not unreasonable. And then there's these new class of medications that are called PCSK9 inhibitors. And PCSK9 is actually identified through some genetic sort of ancestral work to say that's the receptor. There were some people that had very low cholesterols late in life and seemed to have no need for a statin. And so as we went to study them, say, wait, why, how could there be a family that seems to live really long, not have heart attacks, and their LDL seems to be, 40 or 50? How do they get that? And we identified that it's this receptor on the liver that is a potentially opportunity to reduce that cholesterol. And so there are now both antibodies that patients can inject themselves either twice a month or once a month called PCSK9 inhibitors, evolocumab, Repatha, things like that. Those are some of the names people have. I'm using both the drug's generic name and the trade names. And then there's now a small interfering RNA injection called inclisiran, where you can get twice a year an injection, or initially it's a couple times, but then twice a year an injection that goes and inhibits the RNA that makes the PCSK9 receptor and gets the LDL down to 30. So there's a whole army of therapies we could use to get your cholesterol down in addition to diet.
If price were not a factor, would you what would you have people do? I mean, you talked about statins, the amount of evidence that they are good on a population level is huge. The amount of evidence that they're good for primary prevention on an individual level is high, but these
same kind of thing. If this now becomes sort of how people are, right? Like, so I can tell you, like, some people don't mind saying, hey, you know what? I'm going to take Crestor. It's generic. I put it next to my toothbrush. I brush my teeth. I take it in the morning, Manesh, no big deal. Great. That's what most people would say you should do. Some people forget that, don't like it. Say, hey, I don't like the way that has side effects. I've heard that the antibodies don't have as many. No problem. If you think you can afford it, that's not an unreasonable strategy too. And it does one of the other things is it's a little bit more convenient. It's like twice a month or once a month I inject myself. I don't have to think about it. I'm good. The nth degree of that is inclisiran, right? Like, that's a twice a year injection. If you can get all the way to that, that's an even better version. And this is not the only place this is going to happen in cardiovascular medicine. There are therapies coming for blood pressure that are going to have this type of injectable. And so I would say, for most patients in practice, we'll say, hey, because price is always part of it, but also just we have a little bit more evidence with the statins, we would say, hey, start with statins. But I have a pretty low threshold for people who either don't tolerate it, have tried a few different statins, or say, I don't want to do it and I want to do something else. And I have a pretty low threshold if they can get it to get a PCSK9. They're extremely well tolerated. They have a huge, if there's a 30 to 50% reduction with some of those high intensity statins that I talked about, it's equal, if not more, with the antibodies. And so I would say they're tolerated well and they can also be done. The key is to get that LDL down. Another question I'm often asked is there too low a number? And that I think you hinted at earlier. My general feeling, again, I'm a biased from a cardiologist, probably from what I see, but I don't think there's too low a number for most of the people we see. I have some patients where their LDL's, 20, 12 in small numbers. They've had heart events though, right? So it's just a question of where you are on that journey again.
Yeah. It's interesting. I even have some people that with the PCSK9s where they can't afford the full thing, but they can afford half a dose, so instead of $600 a month, it's $300 a month. And, I see numbers that are better than high dose statin. And
I think that's right. And I think some of something is better than nothing. Some of the most powerful thing you can tolerate is your goal.
Yeah, exactly. So kind of last thing I'd love to touch on is, what do you see? You talked a little bit about statistics for 2030. You talked a little bit about, universal screening, what might be in the future. But what are some of the most exciting things coming down the pipes? You already mentioned one therapeutic that's already twice a year, therapeutics coming for blood pressure. What are some of the most exciting things that you see in cardiology coming over the next 5 to 10 years?
Yeah, well, I'll just say it's true in medicine first. I'll start to sort of say, I'll break it up into drugs and devices and data.
Hmm.
Actually, I say now to our residents, medicine is about three things: drugs, devices, and data. And by and far, data is going to be even maybe the greatest one we have to help put into context for our patients and ourselves. So I'll tackle that one last. The drugs that are coming are equally, if not potentially more exciting than we didn't spend time talking about GLP-1,
Yeah.
but GLP-1 receptor agonists, you have to just say, are a revolution and
Yeah.
cannot be overstated enough. We talked a lot about diet, but I will tell you that semaglutide or Ozempic or Wegovy, depending on which versions you're getting, or Mounjaro or tirzepatide, these injectables are really dramatically changing how we think, not just about weight, but cardiovascular disease and kidney disease. And just to make sure everyone's, these glucagon-like receptor agonists are similar to what gets released in your stomach, goes to your brain, and tells your brain, I am, we don't want to say full, but I'm feeling like I'm full and have eaten enough, or at least taking away that urge to eat more. And that slowly titration up is getting people weight loss of 15% of their body weight, 20% of their body weight in some of these studies. And an 18,000 patient study called SELECT-D showed that it reduced cardiovascular events. And so Medicare, even though it doesn't pay for weight loss therapies, are paying for cardiovascular events. And so people who have a BMI 27 or greater, get on these drugs, lose weight, will have fewer cardiovascular events, especially if they have some of these risk factors. So that's incredibly powerful. The big issue is, of course, cost and access. And so that's a big one that has to be solved, and I'm hoping as more therapies come on. There are now combos that aren't just GLP-1. They're GLP-1 with other mixtures with them that do both, I'll say, weight and some portion of what we've seen as support to the heart and the kidneys. GLP-1s have also been shown to reduce kidney deterioration. So I think it's valuable for us to think about that. So the cardiometabolic therapies that aren't just GLP-1 combos and other targets coming are going to probably tackle maybe the biggest issue in that growth curve that I talked about, which is weight, diabetes, and high blood pressure. Other sets of therapies that are pretty exciting are injectables coming that will keep your blood pressure controlled for 3 months at a time. Again, the other strategy I see in cardiovascular medicine is going from, I'm going to give everybody a statin and a same blood pressure pill, to you're going to come in, I'm going to check your burden, I'm going to see what you do to respond to, are you adherent, and then give you the set of injections that best work for you. People having a high LP little a, there are directed therapies coming for LP little a. There are directed therapies coming for other parts of that cholesterol pathway. So all of that precision and personalization in cardiovascular medicine is coming. It's coming for the risk factors. It's coming for a lot of the cardiometabolic disorders. With regards to devices, we do stents and we do valves and we do those things, but the device side is equally exploding because we have a whole cadre of new ways that we can help your heart, if it's not squeezing well, do better, whether it's by changing the nervous input. There's some ongoing studies about how we do that in your abdomen or in your chest with percutaneous procedures. We've replaced the aortic valve from the femoral. Now we're talking about tricuspid clips, mitral valve. So that sort of explosion's coming, and I think will be important. There's 4 or 5 new therapies coming for the failing heart to make it squeeze even better so that we can keep people as functional as possible. So drugs and devices. Before I get to data, any comments about those? And then I'll go into the data version of what I think is going on.
No, I think, I thought about bringing up GLP-1s, and I'm glad you did, because I agree the amount of change we're going to see across medicine because carrying too much nutrition in our bodies is just so detrimental, and the metabolic disease that causes and how revolutionary that is. And I am happy that liraglutide just went generic. One of the pharmacies we work with, I think it's $230 a month now, which is not nearly as powerful as semaglutide, but still, a good GLP-1 that can cause a lot of weight loss and better metabolic health.
I
So
think that's right. Yeah, and they have an ongoing study for cardiovascular events, and we'll have to see if it's generalizable. But I think it's if it's accessible in that way, because that's the part of the issue. I think it's going to be really important.
yeah,
Um, yeah, I think those are the big ones, but there are going to be a variety of other ones. I didn't even talk about the greater than 5 years away. For some of the genetic cardiomyopathies, we're going to have the first studies now to do
mm,
potential gene editing for some of those cardiomyopathies. And so we are moving towards what I'll call is the true frontier. Of course, we got to get people to trust us. We got to show long-term data. It's not easy to
right,
prove these drugs, and it's scary to think about it that they're going to be gene editing. But if you have a cardiomyopathy like amyloid cardiomyopathy, and your family has it, and we could give you a two-shot infusion that changes the genetic makeup to not have that cardiomyopathy, that would be, I think, important. And so that's sort of the futuristic state. One could imagine then finding the PCSK9 and a genetic receptor and saying, can you get to one shot that reduces lifetime cholesterol? And there's a few companies working on that, one in specific. So that now is what I'll call the moonshot for changing lifetime risk. And that would be a big decision treatment, figuring out how to do that. And then data. I'll just end by saying data. And this is, I think, the biggest opportunity in all of health, much less cardiovascular health. And I actually think this is where platforms and places where you start to understand your data is going to be important. So just a few points on that I've made for people. If we took all the information in the world, all the amount of information, knowledge, and data that exists today in 2024, it's estimated 30% of it is health data. That's pretty mind-boggling that almost all of the information that exists on planet Earth, 30% of it is health data. Each hospital on average produces about 50 petabytes of data. Not that petabytes makes any sense to anyone. It's almost like a million bytes of data. 97% of that data that health systems are generating goes unused. So what will happen, I believe, with the generative AI or other types of things where we can take unstructured data and start to learn things, hopefully for the good, will be that we'll have to now, as clinicians working with patients, put sense around all this information and personalize it for individuals. And so we're spending a lot of our time saying, how do we clinically test? Not test in ways that the AI companies might think about it, like, hey, I proved I could predict something. Can I test it to show that I used it to change something for the patient that led to better health? And so I think insights will be important. I think the way I'm thinking about it is there's about 10 things clinicians or patients want out of health. How does the AI help? How do I get my data? How can I visualize, understand it? Who is a trusted intermediary to help me understand my data? And how does my data tell me something specific about my biology, cardiovascular risk, behavior, cancer risk, physical activity? So in cardiology, where that's going to play a role, I believe, initially will be these images that we have of our hearts and our arteries. But I think it's going to move from the images to nudges and ways in which we work with you to keep you on the healthy path, to say, hey, I've noticed that on Thursdays, your blood pressure is higher, and it seems to be higher at night to morning, and there's this pattern that not everybody's going to know. Is there something going on Wednesday nights, or should we be thinking about changing your medicine just to an evening dose on Thursday? And those kinds of smaller moves will make bigger impacts for individuals, and that's the kind of thing I think data will really help us with.
yeah. I mean, I couldn't agree with you more. Data to me is such an interesting space. I'd say it's a bit more of an unknown to me of how much value can we drive. It was interesting, I was at Microsoft when GPT-4 was first being released, and we were so astonished by how well it did at medical tasks. And that fact that you called out, that 30% of the world's data is medical data, helps explain like how it was trained on kind of open resources on the internet. And so there's a lot of medical data on the internet as well. So I think there's so many cool things that we're going to be able to do in that space.
Awesome. Well, I think that's where it's going. But for today, it's about figuring out how to understand your own health stuff and act on it.
Yeah, 100%. Well, Manesh, this was amazing. Thank you. I think, the audience has been lucky to be able to gain from your wisdom, your expertise. Is there anywhere that people should find you online, or anything that you'd like to say to the audience before you leave?
No, I just obviously most of my stuff's on the Duke Health portal and other things, so people can always find me there.